The Miller-McEntire Periodontal Prognostic Index. This is on my web textbook, which you see at the bottom of this slide. What we're going to be dealing with today is part one, which is the background and development of the concept. There's another companion video on there, the clinical application. And in addition to the clinical application, there are 2 or 3 supplemental videos that you may want to look at on the MMPPI, and especially the one on smoking cessation. The index is used to determine the long-term prognosis on periodontally involved molars, but it also can be used on single teeth as well. But single teeth have a much better prognosis because 2 of the factors that we score, molar type and furcation, you do not have on single-rooted teeth. And in initiating this study, I went over and evaluated and decided that I would do this prognosis study, but what I found is I seldom, if ever, lost a single-rooted tooth that I had treated, unless it was lost to trauma or caries. So therefore, we focused on periodontally involved molars only. Now, what do you say to a patient when they ask, if I have this periodontal treatment done, how long can I expect to keep my teeth? Well, that is a very nebulous answer when you say, well, it all depends on this, it all depends on that. And it's not a very definitive answer. But if a patient asks you, well, how much is this treatment going to cost, and you don't give them a definitive answer, the likelihood of accepting treatment goes down to about 0. But patients are very interested in numbers, and we can give them a very accurate number, as you will find out, in a percentage of success. In other words, if you follow the keys to success, which we will discuss, then you will find that you can have an exact percentage that is very accurate. A 96% chance of keeping the teeth for 15 years, a 53% or whatever. And this is to give you the background behind that and how that can be developed. The current thinking now is everything should be branded. And the branding of this, we talk about the Miller-McEntire Periodontal Prognostic Index, but we refer to that as the MMPPI. It is evidence-based, it's statistically validated, it is very accurate, and it was published in the Journal of Periodontology in 2014, the February issue. The next year, it received the Clinical Research Award of the Year, and here is the letter I got informing me that it had been awarded that prestigious award, and a picture of me on the right receiving that in the meeting, 2015 meeting. Now, the Clinical Research Award, there's a committee by the American Academy that looks at all literature that was published within that year for clinical significance, and they select one article which they give the Clinical Research Award of the year. Apparently, they thought this was a very significant study, and it was awarded the Clinical Research Award, the single one for the year on that. How was this derived? This was derived using a patient history and complete periodontal exam of patients in my private practice. And the data was collected on 102 patients, and we had 816 molars. And I've probably reviewed well over 1,000 recall patients to come up with this 102 patients. Actually, we found 106 patients that met the criteria, but data was incomplete on 4 of them. So the case studies in this were 102 patients on 816 molars. Now, why did we eliminate about 90% of the cases? That's because the criteria for selection for statistical analysis was so strict. First of all the patients had to have moderate to severe chronic periodontitis. The patients treated were treated between 1969 and 1994. And that's when many patients were referred by the general practitioner for in-depth periodontal treatment. And obviously, no patient was sent in with minor disease. All of them automatically had significant disease for which the referring dentist thought they needed to see a periodontist. But here is the reason why we eliminated 90% of the patients. Because all the patients had to have all 8 of their molars, first and second molars. And the average patient in the study came in about age 42. So a patient with chronic moderate to severe periodontitis who was 42, in all probability, had already lost one molar. And so therefore, only about 10% of the patients in our recall system qualified for this. And finally, all the patients had to be a minimum of 15 years post-treatment. And if you go to the table in the article and look at comparative studies, you'll find some of those were 5, 10 years, and the classic Wasserman-Hirschfeld study, the patients were in the study 22 years. But in that study, this included single-rooted teeth, it included healthy teeth, so forth, but the average patient was in the study 22 years, so this is actually longer than that study. And one significant finding is we evaluated molars at the initial appointment, even those that were extracted during active treatment. So here's the post-treatment variations on that. They were a minimum of 15 years, but get this next one. They were in the study an average of almost 25 years, 24.2. And certainly the range from 1969 to 1994, they were in the study somewhere between 15 and 40 years. So the 7 factors that were evaluated we see here: age, diabetes, smoking, molar type, probing depth, furcation involvement, and mobility. Now, you will notice that we have probing depth rather than clinical attachment loss, because the term clinical attachment loss we did not use in 1969. Everything was based on probing depth. And certainly if we were going to do a progressive study, then we would use clinical attachment loss. Also, furcation involvement. You're going to find on this study how insignificant furcation involvement is on long-term prognosis. And we're going to come up with an interesting way of scoring mobility. Now, we could not determine a statistically validated score for 2 factors. One of them was diabetes mellitus, and one of them was smoking. So therefore, the reason that we could not come up for a study on that, on diagnosis, is only 2 patients of 102 had reported a diagnosis of diabetes mellitus. This was really surprising to me. I thought that figure would be higher. But an interesting finding, when the study was completed, these patients had been in on an average of 24 years, and how many of them do you think would have developed diabetes during that time? When this has been discussed in seminars, but the participants will say, well, 10%, 20%, 30%. But in reality, only 2 patients 24 years later reported a diagnosis of diabetes mellitus, which begs the question, does reducing the overall inflammatory load have an impact on reducing the incidence of diabetes? And certainly a study that could be evaluated and a research project on that. Therefore, if we were going to do this, I went to the textbook listed below and came up with a way of determining prognosis for diabetes using various levels of A1C score. So these are the scores that I came up with. If they scored less than a 6 on an A1C score, they scored a 0. A 6.1 to a 7, they scored a 1, and a 7.1 to an 8.0, a 2, and an 8.1 to a 9, a 3, and anything over a 9, we scored a 4. Because studies show if they're in the 8 and 9 range, then this is the area where you get retinopathy, amputations, and so forth. So this was what I offered to the statistician, and she evaluated those and said that they were reasonable scores, although they were not statistically validated. Now, my colleague, Dr. Gopal in India, who has followed this study from the inception on that, decided to do a progressive study both on smoking and on diabetes. And this is the one on diabetes, which will be published in 2018. It's been accepted for publication. And what he found, he used these figures that I had, and the statistician evaluated those and determined that the factors that I had selected were statistically valid. Now here's an interesting thing that I would suggest that you look into. They have an in-office testing kit called the A1C Now, which you can order online. And if you order 20 to a box, they come to about $15. And why do I suggest that you do it? Now, I personally am diabetic, and here's the way the score looks on when I took my A1C. I go by every time I see the endocrinologist, I take an A1C there and compare it to what she gets. And invariably, if she gets a 7.1, I may get a 7.0, but we're in a tenth of a point always. So this is very accurate compared to the one done by the physician, and certainly a lot less expensive to do. But what if you do not have an A1C score? What do you do? Well, a patient comes in, you find out they're diabetic, you're doing a significant case, and you're concerned about the control. What do you do? Well, temporarily, you go ahead and use a score of a 2 until you can get an accurate score on that. Or you can go ahead and do the A1C in the office, which I would highly recommend. But what happens when you send the patient back to the physician or to the physician to have this done? First of all, they've got to get an appointment. The scoring has to be done, and it's usually a period of time before the physician gets back to you. And by that time, unfortunately, the patient has lost interest in the case to a certain degree, and you will lose that case. Now, a side comment on this. If you do an A1C in the office and you find it's elevated, remember this is a medical diagnosis, and you should never tell a patient that they are diabetic. You should simply tell the patient that the blood sugar is elevated and let the physician make the diagnosis. For a diagnosis of diabetes mellitus can have a very negative impact on certain jobs. For instance, you have someone who's working on a skyscraper up on a scaffolding and all. If they're diagnosed with diabetes, the company will probably not keep them doing that job. So you don't want anyone to lose the job, but simply say, this test shows that your blood sugar is elevated and you need to see your physician on that. But typically, if they don't want to have the A1C done in the office and you don't have an accurate one, at the initial appointment, you can use a score of 2 as a determining score. Now, determining a statistically validated score on smoking, and we're going to show you how we derive that. And we use a score of a 4 on smoking. But again, Dr. Gopal did this study, which again will be published in 2018, showing that the score that I selected on this has now been statistically validated in a prospective study. Let's discuss the impact of smoking. You have 2 patients that have an equal amount of periodontal disease. One is a smoker and one is not. The smoker statistically has a 246% greater chance of losing their teeth than the non-smoker. And let me tell you, this is very impactful when this is shared with the patient, because they realize that smoking impacts heart disease, oral cancer, lung disease, but they don't realize it has an impact on their teeth. And often this can be the straw that breaks the camel's back in encouraging them to stop smoking. And I would urge you to look at the short video, about 6 minutes long, on smoking cessation. The actor in this video is actually a fellow dentist who is not a smoker, and I'd like for you to look at the expression on his face as we discuss this. He only reacted very naturally, and we only did one take on it. How significant was smoking? 4.9% of the patients were heavy smokers, at least a pack a day, and they lost 26% of the molars extracted. So therefore, this is statistically how we validated that. And I mentioned that we as healthcare professionals should share this information with the patient, but we don't get compensated for smoking cessation time spent, and the overhead keeps going on. So we can refer the patient to 1-800-QUIT-NOW, which they can log into, or telephone rather, 24/7, 365 days of the year. But again, I think we have a moral and ethical responsibility based on the findings of this study to share this information with the patient. Now, an interesting fact, when the extraction data were analyzed, 34.63% of the molars extracted were maxillary second molars. This should come as no surprise to anyone listening to this video, because we all know that the maxillary second molar is the most susceptible tooth in the mouth to being lost. We've known that for years. And a little aside on that, the significance of function. And if someone can give me a reference on this, I would very much appreciate it. But a study done when I was in graduate school as a resident back nearly 50 years ago, there was an article published that showed that each bicuspid or premolar provided 10% function, and the first molar provided 60% function, and the second molar provided 20% function. So keeping a first molar occlusion provides 80% function, and even if we do have compromised second molars, or that should they be lost, maintaining a first molar occlusion provides the patient with 80% function. The way we scored mobility, I think you will find rather unique and very practical in doing that. We all talk about Class 1, Class 2, and Class 3 mobility, and this is based on several factors: how far the tooth can be moved laterally, whether it can be depressed in the socket, and so forth. But let me offer you a more practical way of doing this. Class 1 mobility simply means that a tooth can be moved, but you as a dentist are not concerned that that's impacting mobility. A Class 2 means that you are concerned, and a Class 3 means that the tooth is possibly, but not probably, hopeless, and may under certain circumstances be maintained. So let's talk about the distinction between Class 1 and Class 2 mobility. Let's say that you have a patient who's 29 years old who has lost the molars in the mandibular arch, and is going to have a bilateral free end-saddle partial made, and you're going to use the second premolars as abutments. And yet these teeth are somewhat mobile. Would you be concerned about that? These teeth lasting for many years with a level of mobility and a clasp on it? I wouldn't. So therefore, I would score that as a mobility of 2. Now let's fast forward to someone my age, nearly 80 years old, who has a moderate periodontitis but has all of their teeth. And we're going to score the second premolars on that, which will not be used as an abutment teeth, in an older patient where the teeth are not going to have to last that long. And if both the premolars in the younger patient and the older patient have exactly the same amount of movement, then in the older patient, I would score that a 1 and not a 2 that I would score in the younger patient. And let's talk a minute about Class 3 mobility. Let's say that you have a patient who has had orthodontic treatment and significant root resorption, and the teeth are mobile and actually can be depressed in the socket, and they have a slight periodontitis. All right, they're a Class 3 mobility because they can be depressed in the socket. But certainly you're not going to extract those teeth. They're certainly not considered hopeless. So therefore, by reducing inflammation, perhaps doing some occlusal adjustment, perhaps making a night guard, the mobility could be decreased and the teeth could be maintained. Now, if we're going to treat teeth and keep them for a long period of time, we got to understand about how long teeth with furcations can last. Because what you're going to find is furcation involvement is one of the least impactful things statistically on determining prognosis. And here's a study that found in 2009 that teeth with furcation involvement, if properly maintained, had as good a prognosis as implant-supported teeth. So this is a study that points that out. Now, statistically, let's get into an area. This will be a little bit dry, perhaps, but very important, because we use the multivariable Cox proportional hazard module statistically for coming up what we wanted to do. And we can see the 7 factors on the left, and here we can see the hazard ratio. The lower the number, the least impactful it is. And here we see age, furcation involvement, and molar type as the three factors that have the least impact. The red factor, smoking, 3.4, has the most impact. And as you would expect, probing depth and mobility were significant factors as well. But why did we use the multivariable Cox ratio rather than a relative risk ratio? This is more sophisticated statistics because if we had used a relative risk ratio, those molars extracted during active treatment and during recall maintenance would be eliminated from the study. And that would mean rather than 816 molars, we would have 175 less, so my sample size would have been markedly less. So the total number of extractions, as I said, were 175. Of these, 32 molars, or only 3%, were deemed hopeless and extracted during active treatment. And as I said earlier, this is the only study that I'm aware of that where molars are evaluated on the front end and then either treated or extracted, and that gives data that other studies do not provide. So therefore, 140 molars were extracted during maintenance phase, but they survived, look at this, 15.4 years. So even if you have a questionable tooth that may be lost and you score it and tell the patient it has a 15-year prognosis, how significant is that to say someone's 60 years old? Very impactful, has a lot to do with case acceptance, following through with compliance on maintenance and so forth. So therefore, offer the patients hope, not hopelessness. Now, we used a score of 4 for smoking. Remember, we came out with a 3.4. We rounded it off to the 4, and the statistician said that that was, although not statistically valid perhaps, it was an accurate way of doing that. And Dr. Gopal tested that and found that 4 as a score for smoking was statistically validated. And he did this, as I pointed out, the study that I mentioned that he presented last year in Boston at the American Academy of Periodontology under the Innovations in Periodontics, and again presented in 2018 his prospective study on diabetes. Now, here's the score sheet, and it has undergone many different variations over the years to simplify this. And we can see the factors that we score there on the top left, and in the middle we see the percentages which we will share with the patient. But on the lower right is what is a very, very important part, and that's the keys to success, which we will ultimately discuss. Now, each little dot on these lines represents an extraction, and we can see the green line is a 1. We can see that the blue line at the bottom where the teeth had a lower percentage success. And on the vertical axis, we can see percent, and on the lower axis, we can see the time. So if we draw a line, a vertical line, at 15 years and correlate that with the percentage on the left, this is the way we came up with the percentages on that, and this is where we ended up putting that on the score sheet. Now, the teeth that survived and were still alive 24 years after treatment had an average score of a 4.63. So therefore, if a tooth scores less than 5, the chances of losing the tooth to periodontal disease are rather remote. Which brings us up to use a little ditty that is a little silly, but it does work. And that is, if you want to keep your teeth alive, keep your MMPPI below a 5. And sharing that with the patients, and patients in practices that are using this tend to remember their number. And when they come in for recall maintenance, they like to be rescored to see exactly where they are. And if the score is rising, that is a valid reason for doing some type of retreatment or seeing which key to success they are not providing. Now, 641 molars survived. That's almost 80%, 78.6. And the question going through your mind is, are you keeping hopeless teeth that are infected or whatever? So therefore, this is a position paper published a few years ago by the American Academy of Periodontology, where they discuss survival versus survival in health. And survival in health is characterized by the absence of redness, suppuration, and bleeding on probing. So therefore, applying that criteria from the American Academy, of the 641 molars that survived, nearly 90% met the AAP criteria for survival in health. And that begs the question, do patients still have periodontal disease, or do they have excessive probing depth and reasonable health? And rather than disease, do we have a periodontal defect? And on my web textbook, there's a short video that comments on that, and I would urge you to look at that. Now, if teeth are maintained for many years, in this case 24.2, obviously there's going to be some need for retreatment. And we finally have the answer, and the frequency is, if the teeth are maintained for that many years, they are going to have some retreatment every 6.7 years. And typically retreatment will consist that 60% will require non-surgical treatment and 40% will require additional surgery. And this is a study done by Fardall and her associates, and letting a patient know, even with the figures we're giving, they are going to need perhaps some retreatment every 6.7 years. And here's the important point, the keys to success. And as we go through these, I want you to note that absolutely all of these are under the control of the patient. We as a dentist have absolutely no control over those. And if the patient will follow and abide by the keys to success, the percentage that we're giving them of success will be accurate. If they don't follow through with these and violate any one of them, then the numbers that we're giving on percentage of success are not valid. Certainly patients are going to have to brush and floss, clean interdentally on a daily basis. Well, this is the premise of all periodontal health. We've got to have good home care. Also, they have to complete the recommended treatment on this. They've got to maintain the recommended recall maintenance schedule, and if smoking, they need to stop or cut back markedly. And the figure that I use on that is to cut back to 5 a day and certainly control their blood sugar. Now, on the latest scoring sheet, we have another factor, number 6, and that is the importance of cleaning the tongue. Because after brushing and flossing and removing the bacteria typically found in normal home care procedures, 90% of the remaining bacteria are on the posterior third of the tongue, where you cannot reach with a toothbrush, and if you try to reach back there, you'll gag the patient. So I advocate using a metal tongue scraper to remove those bacteria. And those bacteria are sulfur-forming bacteria that give off the aroma of rotten eggs. So the main cause of halitosis is not the bacteria on the teeth, it's those sulfur-forming bacteria on the posterior third of the tongue. And even if you could get back there with a wet toothbrush, you're not going to be able to remove them. But using some metallic tongue sweeper or scraper is necessary, and there is a video on there showing you exactly how to do that, where you might order those from the individual who makes the tongue scraper that I personally used. So a summary of the scores. We have age 0 to 39 is a 0. Now what we found on that is most young patients with severe disease, we think the prognosis is poor, so we simply treat them with some level of root planing. But if you've got a 29-year-old with 8 and 9 millimeter pockets and a couple of furcation involvements, ultimately most dentists, especially periodontists, feel that that is a hopeless tooth and they'll condemn it. However, if you will treat that patient in depth, go ahead and flap it back where you can get access to get all the debris on the root off. These patients, it turns out, have a much better prognosis than we think. But treating superficially means that debris is left on the root, the process continues, and we have a self-fulfilling prophecy that that tooth is going to be lost. We've already talked about smoking, we've talked about diabetes, and on molar type, when we found the extraction data. The mandibular molars have a better prognosis than the maxillary first molar, has a better prognosis than the maxillary second molar, so therefore these are the values we assigned on that. And look at the values on probing depth. Less than 5, we're not concerned about. 5 to 7 is a 1, 8 to 9, 8 to 10, and so forth, and over 10, how we determine the score for that. Now remember, this was a retrospective exam based on the cases that I treated in a regular periodontal practice, and I did not take the time at the examination to classify the severity of furcation involvements. We only listed the number of furcations present. So you can have 3 furcations on a maxillary molar, you can have 2 on a lower molar, but if you have a through and through furcation, that scores a 3 on a lower molar. So remember, this has nothing to do with the classification of severity, just the numbers involved. And we've already discussed mobility. So the conclusions, if I may. Young patients with moderate to severe disease can have an excellent prognosis if they are treated in depth. If they're not treated in depth, they're going to have a poor prognosis. We've already discussed smoking, and we do need to know, as we have pointed out, that a tooth with a furcation involvement can have an excellent prognosis. So using that as a criteria for extraction is really not fair to the patient. So hopefully this video that I've given here will give you some ideas. I hope that you will look at the second video on this, the clinical application. I hope you will look at the smoking video, for this is a complete system that can be very motivational for patients to accept treatment, to complete treatment, to comply with the maintenance level, and also by sharing these score sheets with family and friends, you can get self-referred patients and not be depending as a periodontist on dental referrals as well. Hope you enjoyed this.